Are you ready to take your practice to the next level? Are you a student and struggling when it comes to really diagnosing the right condition? Do you understand how to look at the way a contact lens sits on the eye? Do you understand the importance of the financial aspect of the way that you practice? Friends and family, I'd like to welcome my colleagues coming on here shortly for Grand Rounds with Eye Care Experts. Let's go. This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover. I'm super excited today because we have an all-star lineup. We have seasoned ODs to an optometry student, and we're going to talk about contact things related today. But most importantly, we're going to help you elevate the way that you practice, whether you're a student or seasoned OD. I hope you guys are ready and game. Now, before we get started, I got to introduce my colleagues on the call with me. And first and foremost, I got to introduce my buddy, my friend, my colleague who has changed the way that I look at contact lens, Dr. Aaron Roof. Dr. Aaron, how are you doing today, my friend?
I'm great. Thanks for the nice introduction, Daryl. Good to be back.
Well, super excited to have you back. You know, we kicked off this series last year and it was a success. So we were able to partner with Johnson & Johnson Vision again for 2024 to bring it back to really help elevate our profession. So thank you so much for tuning in and tapping in with us today. Next up, I have my guy, Dr. Shane Kanar. Man, good to see you again. I remember seeing you not too long ago. We were at Optometry's meeting and we were out there advocating, fighting for the rights for optometrists and really just partnering with Johnson & Johnson Vision and elevating what they do when it comes to advocacy in the eye care space. How are you doing today, my friend?
I'm great. Any day I get to work with you is a great day, and you nailed it there. J&J works so hard to make sure and promote our profession and what we're able to do. I always like to call that out when I can.
Absolutely. I mean, at the end of the day, we have to remember that our profession could be taken away tomorrow. It's a legislative profession. So we have to protect our rights and we have to expand our scope. And the other thing that we have to do as eye care professionals is invest in the youth. And on today's podcast, we have Adam Murray with us today. That's a student of optometry, and he's going to dive in a case with us today. Adam, if you don't mind, maybe sharing a little bit about your background, where you go to school as well, my friend.
Hi, I'm Adam. I'm a current third-year student at Southern California College of Optometry, and I'd like to thank Daryl for that incredible introduction. Happy to be here and happy to talk some contacts here today.
I love it. I love it. Well, we're going to get this party started. For those that might have not tapped in with us last year, we have a Grand Rounds case with you. Just to kind of paint the picture of what this looks like, Dr. Aaron Roof and Adam will sit down and socialize this case, and then we'll bring in the famous and well knowledgeable of anything contact lens related and practice management tips, Dr. Shane Kanar, to really bring it home. And then I'll come in and be comic relief, essentially, right? But don't mind, don't worry. I am giving away 3 gift cards. $100 gift cards to one of you students, one of you new graduates out there. So make sure you watch and tune in because they're giving it away to an end. Dr. Kanar, I think you and I need to step away and let these two experts go at it, my friend. So we're going to let them have it.
Sounds great.
Bye-bye, Daryl.
Hello.
All right, Adam. Well, I think it's just you and me for a few minutes here. So we're going to start on this case.
Sounds good.
Before we get started, I want to thank our sponsors, Johnson & Johnson. As Daryl mentioned, they're great advocates and supporters for our profession, both the protection of our profession and expansion of it. So thanks to J&J. You already met all of us here tonight. Okay, so we're going to talk about a case tonight that I think on the surface doesn't seem that sort of difficult or juicy when it comes to let's really dive in. But this is really what we see a lot as eye care providers, and oftentimes don't manage as well as we probably could have. And when we don't address things that cause dropout in our patients, that's going to obviously cost our practice a lot and cost our patients a lot as well. So that's what we're going to talk about tonight. We've titled this "The Cost of Contact Lens Dropout."
Ooh, scary.
Yeah. Okay. So here's what we've got coming in. I've got a 46-year-old female. let's say she came into our practice about 2.5 years ago. That was the date of her last comprehensive eye exam. And really her chief complaint is that she wants to return to contact lens wear. As far as you know, she's still wearing contact lenses because you prescribed her a prescription for monthly replacement lenses about 2.5 years ago. She says she wore those for a little bit, but they eventually became uncomfortable and she just returned to wearing her glasses. But she doesn't really like her glasses from like a cosmetic or convenience standpoint. And she actually got a PAL recently and hasn't really adapted to it well. And on top of that, she also has this mild secondary complaint of just kind of mild irritation and watering of her eyes. I'll give you just some of the basic clinical information with this patient. So from a refractive visual standpoint, with her habitual spectacles, she's seeing okay, 20/20 in the distance. She's 46, so this isn't that PAL, and she's starting to kind of see a little bit of blur up close. You refract her and pull out a little less minus in the manifest refraction, and note that she could benefit from about a 1 diopter add. Then you look at her clinical data. So I've got kind of the relevant anterior segment data here, and kind of see a few things, just some mild meibomian gland capping, mild staining of the cornea, kind of just trace scattered, nothing really specific, kind of just specific. And then you also note that her tear breakup time is sort of unstable and reduced in both eyes. And just for curiosity's sake, you take a look back at her chart from 2.5 years ago and note that everything is pretty consistent. So she had a little bit of nondescript staining, kind of reduced tear breakup time 2.5 years ago, and her refractive data wasn't that different either. So knowing all of those things, what kind of stands out to you that may have indicated that this patient was at risk of dropout 2 years ago? Because we prescribed something for her then, was fine with that then, but something happened that made her drop out and then not come back when she was dissatisfied. So do you notice anything either refractively or symptom-wise or clinical sign-wise?
Yeah, I'm seeing a couple different things. First, she's being fit in a single vision contact lens and she's in her mid-40s. So she's starting to get to that age where she may notice things up close aren't as clear as they used to be. As far as clinical findings, the tear breakup time was a little bit reduced, and she's also noting some dry and grittiness feelings. So there's a couple different things, both our objective clinical findings as well as subjectively, that are kind of red flags.
Yeah, definitely. You make a good point that there's sort of a lot of things that are red flags there. Is there one thing in particular that's like most important to you there, or do you feel like it's like the combination of the facts and features?
I would say it's more of the combination of the facts, because she may be noticing that stuff up close isn't as clear as it used to be, and also these lenses are kind of making my eyes feel dry and gritty. So that might be, all of those might be contributing factors for her no longer wearing those lenses.
Yeah, I agree with you. It's hard to sort of pinpoint one thing as being the indicator, and when so many things are relatively mild, if we don't kind of consider them as a whole, then we overlook the problem, the bigger problem, and then probably got to this position in the first place. So as we move forward today, I kind of want to maybe outline a strategy for identifying, each of those sort of subcategories so that you can also kind of bring them together. Because I completely agree with you. Dryness or grittiness and some blur up close might be confused as one or the other. So this is sort of how I like to organize things in my head to make life easier for me. And so based on what we kind of just talked about, I think we could kind of identify 3 distinct groups of kind of risk factors for determining if our patients are at risk for dropout. And those would be subjective symptoms. So what the patient's telling us or not telling us about their symptoms, things we see clinically in the slit lamp, and refractive information. So you already mentioned some of those things. Were there any really subjective symptoms that she was saying besides the dryness? Is there anything we could have maybe identified?
Yeah, she did just note like kind of the general symptom of uncomfortable lenses. That could be dryness. That could be more like accommodative issues, because we know that she's nearsighted, and our nearsighted friends or counterparts will need to accommodate more when wearing contacts. So that could just be accommodative. It could be the dryness, or it could be a mix of the both.
Definitely. It's good to note that, yeah, subjective symptoms can kind of be confused for one another. Another thing that would be good to note in this situation is that 2.5 years ago, she said she was fine. She didn't really have many subjective symptoms, although she did have some clinical signs at the time. Sometimes when you're trying to really screen for patients who symptomatically might be at risk for dropout, using a tool like a survey that can sort of quantify their symptoms can be helpful for you as the clinician to identify those types of patients. I think of surveys as sort of an objective way to measure subjective symptoms. So I'm sure the students watching and listening in today are familiar with surveys like the CLDEQ8, which is great for targeting or quantifying symptoms specifically related to contact lens discomfort. But other surveys like the SPEED survey or the OSCI can quantify dry eye symptoms that might be correlated with contact lens discomfort. Another thing to keep in mind is that no survey can replace a thoughtful conversation with your patient about what symptoms they're experiencing. And, being a human is important, right? And to actually have that conversation with your patients about the nuance of what's working with them for their contacts and what's not working for them with their contacts. What clinical signs stood out to you the most there?
I would say more the dryness, because I feel like she had we saw the tear breakup time was reduced, and she had that symptom of dry and grittiness. I feel like that would be something I would want to manage first, maybe get her on a more robust dry eye regimen, some artificial tears. I know we have a saying in our clinic that we want to be more proactive with our artificial tears rather than reactive.
Yeah.
Because when the eye feels dry, it's already too late. We're kind of fighting a losing battle with tears once the eye already feels dry.
Exactly. I think this case is a good reminder of, I love that. You're absolutely right. Proactive instead of reactive with tears. 2.5 years ago, she was relatively asymptomatic, but the signs were there.
Yeah.
You wonder if we would have, started that artificial tear regimen 2 years ago, if that would have helped her maintain contact lens wear or stay in it longer, more comfortably. So thinking about those signs before they become a problem and addressing them is so huge. Another thing, she did have some meibomian gland, irregularity, maybe lack of productivity. In future grand round session, we're going to talk more about meibomian gland disease. And so that's something we also want to really keep an eye on and consider, not just the tear film and the ocular surface. What about refractively? What really stood out to you kind of refractively? I know you kind of mentioned the presbyopia.
Right.
Do you think she needed an ad 2 or 2.5 years ago?
She probably did, but it was just clear enough where she wouldn't appreciate it quite yet. And we could have just plant the seed at that last visit, telling her if stuff becomes too blurry up close, there are contact lens options, because I feel like a decent fraction of the population doesn't even know that soft multifocals even exist. So just kind of planting that seed, hey, come back and see me if stuff up close becomes a little bit too blurry, and we can explore those options.
Yeah, definitely. Planting the seed is so important for so many reasons. So first of all, you're right. She's 46 today. Let's say she was 44, 43 last time we saw her. She was probably able to, maintain a clear image for a period of time, but that doesn't mean she wouldn't have appreciated an ad.
Right.
And in 2024, when we're all spending so much time looking up close and looking at screens, patients in their mid to late 30s can actually benefit from an ad, not because they need it to make things clear, but they just need it to help, relax that accommodation so they're not having to work so hard all day. So yeah, I love the idea of planting the seed because one, even if she wasn't ready for a multifocal then, she'd be ready now.
Right.
And two, maybe if you planted the seed then, instead of dropping out, she would have come back and said, hey, I'm ready for that multifocal. I'm going to show a graphic from our sponsors at J&J were able to share this graphic with me of kind of showing that as we kind of look from left to right on these percentages here, most of our contact lens wearers are near or in the presbyopic age range. Most of them want to continue wearing contact lenses, but most of them will drop out at some point. And so this can be encouraging statistics or discouraging statistics. So I take this as these patients are motivated to try presbyopic options. We just have to offer it to them. So just kind of keeping this in mind, if you have someone in or approaching that presbyopic age range, you should really think about obviously addressing their ocular surface, but also making sure you've got their visual, unique visual needs in mind too. So, we've called this case the cost of contact lens dropout. And I think the most obvious cost or the first cost that you might think of when a patient drops out is the lost revenue for a practice. And that's certainly something to consider from a practice management standpoint. So obviously the patient's voluntary dropout is going to cost our practice, lost material fees, lost exam fee revenue. If we would have done a really good job for her 2 or 2.5 years ago, she might have sent new patients to our practice and just would have established a sense of loyalty with this patient. So that's sort of an obvious cost that is easy to kind of talk about or quantify. But maybe a less obvious cost is the cost to the patient. So, this patient has, normal vision. She has healthy eyes. So you could argue, or someone might argue that, her not being in a multifocal or even a contact lens in general for the last 2 years isn't that big of a deal. But she pursued contact lens wear for a reason, whether it was 2 years ago or way before that. And that was clearly something she wanted, something that maybe provided her with better comfort or cosmesis or just improved her quality of life. And so that is an important cost to consider, that's something she sought out and couldn't achieve for herself. And that's a cost that we should consider as well. So the next step in this case would be to talk about sort of how we would better address this patient now, how we could have maybe better addressed her needs or anticipated her needs in the future. And so I'm going to bring in Dr. Kanar to kind of discuss with us kind of how he would approach a patient like this. Hello.
You guys have hit on a lot of key points. And I think this is a great case. Speaking as somebody that's 52, they always say your practice ages with you a little bit. There's some reality to that. So this is a lot of my day and definitely something I see. Couple things I want to call out. Both conditions you're really talking about here today, dry eye and presbyopia, are progressive conditions. And we don't always think about that. We think, do they have it or not, like an on or off switch. And both of those conditions start mild and they progress. And you mentioned being proactive with tears is spot on. When I think about this patient, it's so important for me, one, to really do a down and dirty dry eye workup, I would call it, put in lissamine and fluorescein. Remember, level 1 dry eye is symptoms with no clinical signs. So if they have complaints with our new classification, that is an early dry eye patient. Maybe not needing pharmaceutical intervention, but needing our help to prevent that inflammation from developing in more significant dry eye. And you guys made a great call out on early presbyopes. And, I think if I surveyed our profession, so many people would say presbyopia is blur at near. And that's really more moderate presbyope, right? That's a plus 150 ad and above. When you're plus 75, you're not going to say it's blurry at near. You're going to say there's fatigue because your accommodative system is trying to work in a way that it can't.
Exactly.
In our practice, fitting those late 30, early 40-year-olds with one multifocal and one spherical lens has really been a boon for us because we relieve those symptoms and we kind of work them into, hey, this is available for you. So I think we need to call that out. And when you want that, you want a lens that provides nice, clear optics at all distances. And that's where the Moist and the Max multifocal have been so great for us. That pupil optimized design tends to give patients the ad they want when they need it and adjust for their script. So that's been a great thing. When you're looking at dry eye, I think sometimes we forget how much material matters with our contacts. We talk about modalities. We talk about whether it's spherical or not, but materials make a great big difference in what that patient has. And as practitioners, we should know more about that and what all the materials bring to the table. And if you look at Oasis, having not been beaten in a clinical trial, That shows you what that family of lens brings in a peer-reviewed clinical trial. That shows you what that lens brings to the table for our patients. And if you think about One Day Oasis and the design of that material, it was really made to mimic a portion of the tear film to provide that comfort. Why does that matter? You know, in school, and I know I'm old, but we were trained the blink rate slows by about a third when you're doing near task. There's been a study that's come out in the last couple of years that shows not only is the average US person spending 13 hours a day on a screen, which is mind-blowing, that the blink rate reduces by 60%. That's
Wow.
2/3 of your blinks. If you round to 15,000, you've lost 10,000 blinks in a day. You need something to help that eye maintain homeostasis and in that clear optical field that you want. One Day Oasis has been a boon for us. I think of it as it's just providing that next layer of tear film for our patients. Now, go back to what I mentioned about 13 hours on the screen. We're all learning about blue light, and we're learning and we're seeing studies come out about the impacts on the long-term health. But what we can substantiate today is that blue light causes visual distortion. It causes eye fatigue. We can support that. And Max provides this wonderful blue light filter that really sharpens things up. Speaking again to my age at night, I love driving with Max in just because headlights, it's hard to realize, but as you get older, that light scatter, doubles by the age of 60, triples by the age of 70 with the crystalline lens in place. Max lens helps reduce that and provide that sharp vision that we all want. So I think you guys are spot on with the way you're treating this patient. What would happen for me clinically? I would know to watch for dry eye in the future. I think the questionnaires that are quantitative are so important because not only can you see if they're advancing in disease, you can see if your treatment is reducing those complaints. So quantification is big. And then when we talk about the cost of our practice, you brought up the slide that showed, and in just a couple little wording things that jump out to me, it's really over 90% not want to wear contacts, expect to wear contacts.
Yeah.
They expect us to keep them in a lens that is comfortable and provides that visual clarity they want. And it's not that they drop out by some age. Over half have dropped out by the age of 45. That's a 5-year window we're losing patients. If anything else was happening in your practice at that rate, you would think, oh my gosh, how do I address it? And those patients, from a profitability standpoint, are so important in your practice. An existing contact lens wear is a fuel to a practice, especially that 45-year-old that's starting to develop dry eye or complaints. We also know that those patients have disposable income to buy other materials in your practice. And I can tell you 45-year-olds talk. And if you keep them seeing clearly, it is a traumatic life event when you can't see at near. Having grown up and been around it and working in eye care for 20 years, the first time I couldn't see something at near, it was devastation. And
yes,
I don't know if it shows up on this podcast, but my hair may be completely gray already. And it's that happened early in my life, and that was not as devastating to me as trouble seeing up close. So being proactive and engaging those patients and letting them know what is coming, as you mentioned, Daryl, you look like a genius when you tell them. They're going to tell their friends to go to you that have complaints. So you increase revenue per patient, you increase overall practice revenue, and most importantly, you provide the highest quality care, which is all of our jobs, by understanding contacts, understanding materials and benefits, and proactively looking for signs and symptoms. So you guys nailed it with what you're doing.
Oh, phew. Okay. Well,
Nervous.
I'm glad that we get your seal of approval. You made so many good points there, Dr. Kanar. One thing I wanted to ask you, because I get this question from students a lot, because you told us a lot of information about the different lenses that benefit your practice the most. You've practiced for some time now. How do you keep up with all the new technology that's coming out? Like, how do you know what's the newest lens? And how do you make yourself sort of educated on that to understand what would be best for your patients besides just trial and error? Like, how do you educate yourself?
Well, trial and error is part of it, but there's really a
Yeah.
few things I look at. Read journal articles. I mean, if when I talk to people coming out and starting practice, whether it be disease state or contact lens, read journal articles. Dedicate an hour a week to that to stay current, because you will quickly move away from what's current in school.
Mm-hmm.
Second, be engaged in education. You need to, sometimes we can check out when things are online, but you need to be engaged and you need to really try to delve into it. Um, and it's so important, again, to provide that level of patient care that we want. And, the next one is interesting when I talk to people, but having been in practice a bit, you find people that are like, oh no, I'm keeping my reps hands off. I'm not engaging. Those reps are there to partner with us.
Yeah.
They grow if we grow. Obviously, they have a commitment to their product, but you ask them questions, delve into it, and learn what the positive features are. I think all of those things become so important as you continue to practice to stay relevant in what's happening.
Yeah, I agree. Your reps can be such a wealth of information, so definitely don't underutilize them. Definitely. Awesome. Well, I think maybe we can bring Daryl back in. I know he's hovering out there somewhere.
Thanks for having me back. Fantastic conversation. Wow. I've learned so much, and I can't wait to get into the practice tomorrow and implement some of these things. I mean, I want to kind of touch on the gems that I took. Number one, that last little bit there, Dr. Kanar, trial and error, read journal articles, be engaged in education, and partner with your reps. I think that rep piece is the piece that a lot of people don't understand how powerful that is. Your reps are the key to success. They know everything about that product. And if they don't have the answer, they will find the answer for you. On top of that, it's not just with the products and services that they bring to your practice, but they may also know a technician down the street that may not like that practice and want to come join your practice. There's so much that your reps know that you got to befriend them. I'm telling you, that's real talk there. But I want to take a step back a little bit more. Something that Adam stated. And I love this because this is what I do every year, and that's planting seeds. Planting seeds is so important. This is the game changer. You always want to be that doctor that educates about the latest and greatest technology, even if a patient's not ready for it, so that they don't go somewhere else and they hear it from another doctor. You always want to be the one that updates that patient. You always want to be the one that plants that seed. So if they see that commercial on TV with JJV, you come top of mind because you've planted that seed. The other thing I wanted to touch on that goes along with planting the seed is the opportunities with our presbyopic patients. I see opportunity whenever a patient comes in and they're presbyope. No one ever wants to fit them because they feel like they're difficult. But with this lens, the Max, there's a fitting calculator. You don't even have to think. You just plug and play. I mean, that's the game changer, right? So do away with all the thinking and just plug it into the calculator and get a precise measurement, the exact lens technology that the patient needs. And then lastly, Dr. Kanar, you touched on this, and I saw some of the guests on today's call chiming in about it. Cataracts. It's very important to get to know your patients and understand what complaints and problems that they're experiencing, and make sure you find a solution that accommodates that patient's problem. We know that there is a growing, the more seasoned population is growing and is starting to boom quite a bit. So what are you doing outside of glasses to help reduce some of that discomfort driving at night? That Max lens with that blue light protection is a game changer. And that pupil optimized design, you're not going to have to worry about all the halos and all that other jazz. It really changes the game for your patients. So make sure you have the right product knowledge. Make sure that you plant those seeds, and make sure that you realize that opportunity that's sitting in front of you. Not only is it going to help that patient live their best life, but most importantly, it's going to help elevate your practice and increase that bottom line as well. We really got to think about these things. But look, I just wanted to thank y'all so much for all these gems. This is fantastic. Dr. Roof, Dr. Kanar, any last bits of wisdom that you would love to bestow upon all these students and new graduates out there?
No, I think you just summarized it really well. Yeah, I think really the point of this case is, consider dropout before it happens. Consider your patient's risk for dropout, and realize that the patients that are most likely to drop out are going to have comfort, ocular surface, and visual needs that you need to consider in whatever the product is you're suggesting to them. So, yeah.
Just one quick thought, and I see it a lot with practitioners. When you learn about a new technology, whether it be spectacle lens, contact lens, pharmaceuticals, we try it on one person and they are pass or fail, and we make all of our decisions based on that. Try it on 10. Try a new technology on 10 people. Make sure you have a touch point with them and you find out if it worked the way you expected it to, and then make a decision, because there's no one solution for everybody. That's our job, and our job to start to refine who it works for. I usually go to Johnson & Johnson first because their contacts provide me the best option at that first time success.
I love it. I love it. Thank you so much. Adam, any last words from you, my friend?
Not really. I hope everyone tuning in at least learned something or got more motivation to fit some multifocal lenses. And thanks to Defocus Media for having me on.
Oh, anytime, my friend. So thank you again so much for tuning in. We are giving away 3 $100 Amazon gift cards, 3 of those. Thank you for everyone tuning in. Very important to give back to the community. So that's what we like to do here at Defocus Media, and also create authentic dialogue. We love all the support that you guys are giving us here in this chat. Thank you again. You've kept it going all night long. So our winners for this evening, let's see. We have first is Ria Desai. Desai, you are an official winner. You will get an email from Sam, my assistant. She will email you and get you that gift card. Next, we have, excuse me if I'm messing this name up, Mayakai King from New England College of Optometry. And then last, we have Crystal Franklin. So those are our 3 winners this evening. Again, thank you so much for tuning in. This has been fantastic. It looks like our next event is April 15th. Make sure you tune in. We will give away 3 gift cards again. But most importantly, we will have Dr. Shane and Dr. Aaron back on the call, and we're going to have a pretty interesting case for you guys. So make sure you tune in. Thanks again so much for hanging out with this evening. Everyone out there, make sure you stay healthy, stay positive, stay blessed. And until next time, peace. Hey, family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.